for the last.
Okay, welcome everybody. Thank you for joining us in this particular session. We're really thrilled that this is a topic of interest to you. And I think by the time we end, it'll be even more interesting as you hear how different people are thinking about it. My name is Amy Stevens. I'm the general manager over our provider business at Innovaccer and spent 20 years being a health system executive as a chief operating officer, chief strategy officer, and president of a CIN with a plan. So I have a little bit of empathy for my colleagues here up on stage with me. We're going to go through a variety of themes today, but all of them really are talking about the hybrid business you're in. The fact that for most organizations, they don't have just one type of payer contract, or they don't have just quote unquote at risk or VBC, but you have many more variants of how you get paid, including not getting paid. And so how do you in fact take care of patients more broadly in the sort of truest sense of the word population health, but how do you bring along what you have learned and what you have put in place as infrastructure for those things that have been contract specific as opposed to contract agnostic. And so we're going to just go down the line here with the first question. People will introduce themselves, tell you a little bit about their organization and their role, and also how they think about population health writ large. So I'm going to start with Amanda to my left. Amanda.
Hello, I'm Amanda Benites. I'm a nurse by background, and I'm the director of ambulatory quality for Prisma Health, and have special work for our arm as the MVO Health Network with our value-based population. That footprint's around 600,000 covered lives right now. What's your question, Amy, again? How are we thinking about this?
Tell us a little bit about the system that you're connected to.
Yeah.
Maybe it's philosophy around at-risk contracting versus commercial, Medicaid, et cetera.
It's been interesting for me. I spent most of my career with patients in operational leadership, not in the value space. And when I came into it, I thought, I've been here this whole time and never really understood what it is that we were trying to do in value-based contracting. So do I understand yet, 4 years in? The jury's out on that, I guess. But I'll tell you, I think as a nurse, I had to feel very anchored to the work that we're doing as it relates to how we're helping actual people. The stakeholders we need to engage to get the work done, to be successful in a contract, are generally driven by that same thing, by altruism, not by predictive analytics around where the funds are going to flow. They don't really want to hear about that at all, which is good for me because it's probably my least favorite thing to talk about. But coming into it, actually, when you think about change and sustaining the pace that we have to sustain to be successful in VBCs, if you go to the principles of change and sustaining it, thinking about systems thinking and human factors and all of this, that's what's going to give you a result at the end of the day. So when you talk about how do we shift from thinking about the value-based population to thinking about everybody, for me, it's not a shift, because if you don't hardwire in the global population the behaviors and methodologies to deliver that result, you're just chasing your tail. You're just talking about gap closure. You're just talking about the things that should be an isolated strategic arm of the program and not the body of it. So for me, we do have a good system philosophy where I've been able to deploy lots of programs that are payer agnostic, and then have that tactical arm using predictive analytics to chase down the gaps that remain, but build a whole lot of momentum in the broader population. That way you don't have to worry about when the attribution is wrong, which is all the time, or when people ebb and flow in the different programs, because you've built something that's going to deliver the right thing for that person where they are, irrespective of what programs that you have them in. So I've enjoyed that about our organization's philosophy.
Okay, you've given us a lot to think about. John, you can now do yours.
Great. Well, good afternoon, and thank you for having us here, Amy. And I am the Chief Digital Health and Analytics Officer with Cone Health. Cone Health is a Central North Carolina delivery system or integrated delivery system. We have about 200,000 lives in formal risk arrangements. And we think about a population health or value mindset in a lot of ways. Cone Health is also the second of the Ryzen Health organizations. How many people are familiar with Ryzen or the Ryzen concept? a smaller number,
Yeah, it looks
a few
like,
number.
go
I
ahead,
guess
go
we're
ahead and
gonna
take
step
it.
backwards.
That's exactly, quick
So
detour.
for those people that were stepping up, what is Ryzen part of? KP or Kaiser. So I think many people here will be familiar with Kaiser's care and coverage model. Ryzen Health was formed out of Kaiser probably 2 to 3 years ago with the idea, the philosophy of how can Ryzen take some of the best policies, practices, care model work from Kaiser, standardize it, and apply it. Geisinger in Pennsylvania was the first Ryzen Health organization. Another organization where a large health plan, a large employed group at Geisinger. At Cone, our 200,000 lives, our attribution is about 50% with our employed group and about 50% in our independent providers in the community. So clearly different than Kaiser, different than Geisinger, really looking at what we refer to as the multi-payer, multi-provider space. So in those 200,000 lives, about half of them are in Medicare, a REACH program and Medicare Advantage with a variety of payers, commercial risk, Medicaid risk within the state's program. We, I think, have about 17, 18 different contracts. Within our independent groups, primary care, we support over 30 different EHRs that we're moving data around. So we have a set of questions and opportunities to say, what is a strong care model? And for those that were earlier, we talked both Kaiser, Ryzen, Cone, lead with our care model, and then look at how can we deliver care and success in that. So when we think about all lives, we absolutely think about a model like Kaiser. What would it take to deliver care that is successful when you're in a value-based care contract and is good care in a fee-for-service contract as well? And I think we're going to dig into that some more. Mm-hmm. So that's sort of the background of both Cone, and happy to talk more as we do today about Ryzen, some of the Ryzen works, and how this fits into really true population health at scale. I think the Ryzen question is, can you bring many of those best practices, both standardize on one hand, and then localize or contextualize to deliver value-based care at scale?
That's a big question, but Tori, you get to go first or next.
Yeah, so I think we'll take a smattering of all of us in sort of this conversation, and I'll kind of just describe who I am. So Tori Bratcher, I serve as Assistant Vice President for Population Health at Trinity Health. We are a large Catholic healthcare organization. We operate in about 26 states, full integrated delivery system, so 125 hospitals. We employ about 10,000 providers, but we also work with about 20,000, 30,000 non-employed providers within about 12 clinically integrated networks across the country. And that's really our operating model for population health, value-based contracting, direct to employer. We do also, a number of commercial contracts, Medicaid with the states or insurance companies, MA. We have our own plan, our own MA plan, I should say. And so we're sort of in value. We've been in value for a long time. I mean, really early adopters into the early days of, the pioneer model, the demonstration projects. We've always sort of been at the table. And I think that's, when you talk about philosophy of what we're doing, that's really been at the core of our mission. And we're a very mission-based organization, which is really to serve the communities we're in. And I think maybe a similar thread through this panel here is that, we are in these communities from both an anchor institution, but also our providers, our community providers, and we're not going to leave those communities, right? So we've got to figure out a way to be able to deliver cost-effective value care for both our providers, our patients, and in some cases, the insurance companies are where we are, the insurance company as well. We've got to figure that out, because if it doesn't work, we can't just leave, right? The community's counting on us, and that's really part of our mission, is to deliver better care to the communities we serve. So hopefully, I think through this panel, we'll kind of talk a little bit about how we're doing that or how we think about that, but value-based care and population health is very much a big part of what we do sort of every day, and trying to do that for more people, hopefully, as we can scale more things.
That's great. Thank you for giving everyone an overview. It kind of gives everybody a baseline of where they're coming from. We want to start with the foundation of often the bedrock of a value-based care or at-risk contract, and that is the concept of risk. How do you define risk? What is risk? I was recently talking with the health system CEO, and he said, I don't want any more of those risk patients, none of them. And I looked at him and I said, but you're at risk on every single contract. Tell me any contract where there can't be a clawback in some way. The way the network's configured, you've got a penalty for readmission. In your uninsured, you're practically capitated, right? There you have margin risk for Medicaid. The more expensive it is and the more they rotate and use the ED, that is high risk to you from a margin perspective. So like every contract you're in is at risk. But still, we have very formal ways where we think about risk because these are businesses we run and they often are attached to a contract. So talk a little bit about maybe do you have different definitions of risks for sort of your at-risk contracts versus the rest of the organization? How are you, handling that? Tori, since you went last time, I'm going to let you go first.
So yes, we do have a formal definition, I guess I would say, for patients that are in a alternative payment model. That's what we call them, but value-based arrangement. And that is all the way from sort of the P for P, or we use the LAN framework, so category 2 and up, all the way up to category 4. But we also, to your point, as I mentioned, since we operate many hospitals within a geography, and we are also the safety net hospital in many of those geographies, anyone who comes in our door, whether they have coverage or not, and because that's becoming an increasingly bigger challenge for people to have insurance coverage, we are trying to frame this population in a way to our CFOs of the hospitals who maybe have not thought of this, but even some Medicare patients, the margin from a hospital admission on CHF, for example. We sort of use this as an example to try to talk their language to say, you're losing margin on a hospital admission with CHF. Let us manage that patient in an appropriate way with our tools to be able to make that care more effective for, again, both the patient and then you can fill that bed with a higher acuity patient. So that's the concept. I think where it becomes challenging is the delivery because it's cost resources to deliver those types of extra services. I mean, we would love to be able to have a care manager for every single patient but of course that's not scalable. So then it comes into this technology piece of how do we, whether you call it care management light, right? Which is they show up at your ED and you try to figure out how to navigate them through the system or to a primary care provider so they don't show back up at the ED, right? That's a different care model maybe, or it's the same care model, but a different touch on the care model than this proactive outreach for care management based on a risk profile, because we have more data on those patients with a risk profile.
Well, we're often very familiar with case management, care coordination, care navigation versus quote unquote full-on care management.
The full court press, because we just don't, to your point, we'll have claims data on some of these patients. We won't get claims data on other ones. So you got to do different things.
John, you look eager to jump in.
No, I love everything you're saying. I just, that notion, and it was making me think of lots of different threads here. So one of them is I think we have actually done a disservice to ourselves in thinking about our value-based activities over there. And I think you touched on that, Amanda, as you talked, that you worked in a system and you weren't even sure what was going on, but stuff was going on. So we started down this road of it happens over there. It's not part of our core business. And I think the other thing you said is this notion of we don't think about healthcare in the margin business nearly as much as we should. When we talk about the size of healthcare systems, what do we often talk about? How much revenue? And we're growing revenue. Would you rather be in a $4 billion business with questionable profitability or in a $3.5 billion business with sustainable 5, 6, 7% margins that were predictable?
We'd love to have 5% margins.
I mean, how many people at systems here, particularly on the not-for-profit safety net, we're talking about 2 and 3% at best, one policy change at the federal or state level that we don't control. We could deliver care perfectly. One policy change is a difference between profitability or not in a given period. So we have to talk about margin. I think your example, Tori, this notion of a medicine admission through the ED for chronic condition that aren't served because we don't have access in primary care, we don't have an appropriate urgent care, costs us money. Mm-hmm. And if we're not willing to say we can invest that dollar it costs us to free that up, we're really not where we need to be in population health and value-based care. We chase admissions. We keep our beds full. We ask the question of, we're going to make the ED more efficient so more people can come through. But we don't talk about why are 20% of them there in the first place? And do they need to be one of the most expensive conditions or settings that we have? And that is a shift when we think about population health or value contracts and risk over here. And I like the way you frame this, Amy. The uncompensated care, we're 100% risk. Why are we not figuring out programs for them, understanding that we save ourselves money in doing that?
Yeah.
So this construct of population health for all lives is critical, I believe, to our shift to better health in our communities. So that's sort of